into my internship year. Well, we were in my training clinic the first 5 years of grad school, and even on my placement, we didn't have quite as much pressure for this. Because we were sort of, it was understood we were training. We didn't have to have a diagnosis right away, right? We could kind of figure it out with our supervisor before we wrote up the intake report and things like that. But when I was working at the Medical College of Georgia in their outpatient clinic, we only got an hour for intakes. And by the end of that hour, you had to have a diagnosis to write on the paper so that the front desk people could submit and get it reimbursed. Otherwise, the client would have to pay out of pocket. This was challenging as a trainee. I'm sure as you're someone who works within that system, it probably gets easier. You figure out shortcuts, right? But it also, to me, is sort of like probably not best practices in terms of there are things like personality disorders that probably need a lot more assessment than that. Sometimes you need it to communicate with other clinicians, right? So if I am referring a patient for medication to a psychiatrist, and I say, this person has generalized anxiety disorder. They know what that means. They already in their head are thinking of the possible medications that could help that person. And many diagnoses are likely biologically caused. I actually just talked about this in my clinical neuropsych class yesterday, that there are genetic components to the vast majority of disorders. There are biological things that happen in the brain with your neurotransmitters. Some even have like structural differences in the brain, or like connections aren't just clearly made in the brain. And so definitive diagnosis is needed for proper treatment, especially again, if you're going to refer to someone who's going to prescribe medication. And it's also really helpful for case conceptualization and planning out what treatment you're going to use for them, right? So I would actually use the same treatment underneath the umbrella. I was trained in cognitive behavioral therapy, so just about any client I saw, I would use some form of cognitive behavioral therapy. But cognitive behavioral therapy for depression looks totally different than cognitive behavioral therapy for eating disorders, right? I don't need to have my clients who are depressed fill out food records, right? Same thing. If I have someone who has an eating disorder but no history of trauma, I don't need to go through everything I go through with them, like recounting their trauma like I do in cognitive processing therapy. So it can be really helpful for that. One of the things I wanted to say real quick too, especially for folks near the window, if you get too hot, feel free to like crack the windows if you're okay, don't worry about it, but the heat is on, and once the heat is on in this building, it's just on. And you can, like, the blower is off, but it's still gonna be warm, so. Alrighty, so I believe your book still talks about the DSM-4 TR. I think it might have come out in 2012. We are now on the DSM-5, but just to give you a little bit of a history of the DSM-4, diagnosis itself is derived from the Greek words dia, which means apart, and gnosis, which means to perceive or to know. And the first DSM was developed in 1952. So before that, it was a little bit of the wild, wild west. It's like there was some taxonomy and some agreement on what was what. But this was the first time we had like formal criteria. This is how you diagnose someone. And we've been through obviously various iterations. Disorders have been picked up or dropped or renamed or reconceptualized. Like there used to be a passive aggressive personality disorder. And then I think it just got to like everybody does right as we move forward. So things a lot, but also things that are much more serious, like for example, homosexuality used to be included as a diagnosis, and it's not anymore. Hasn't been since the 70s. So they used to use this 5-axis system, basically until the DSM-5 came out. This is what we did. And so this was what I was trained on, where like axis 1 was most of what you think of when you think of psychological disorders. Depression, anxiety, PTSD, substance abuse, any of that stuff would have gone on axis 1. Axis 2 was your personality disorders, and we did used to still use the R word. We don't do that anymore. We talk about developmental delays. Axis 3, you'd list their medical conditions, which was really helpful, especially if you're working in a health psych setting, right? If someone is really anxious and they just got diagnosed with cancer, right? Perhaps that's not a diagnosis as much as it is like a reaction to what's happening, right? So you have to suss that out. You would list like the social and environmental problems. And then there was this global assessment of functioning, which was essentially a 0 to 100 scale of how well they were doing overall in their daily life. So like most outpatient clients would be somewhere between like the 60s and the low 80s. An inpatient person might be much lower. But for whatever reason, when they brought out the DSM-5 13 years ago, 10 years ago, they decided no more of that. You can still note these things in your report. They're just not as easily accessible as they used to be. And I'm obviously super biased because I was trained on the 5-axis system, but like it feels a little bit like a loss to me because you're getting less information when you look at the diagnosis part of an assessment report now. That being said, the DSM-5 does represent some strides forward. But there are some things always with the DSM that we need to be aware of. I'm just going to flip forward in my notes here to see if I talk about this. I do not, so I'm going to take a little sidestep and talk about this real quick. So the DSM-5 or the DSM of any iteration is published by the American Psychiatric Association. So it's the association of people with MDs who treat mental illness. And this is nothing against psychiatrists. There are, just like there are a variety of good to bad psychologists, there are a variety of good to bad psychiatrists, just like any other field. But in general, psychiatrists nowadays get a lot less training in therapy and assessment than do psychologists. They don't always do research like psychologists do. And unfortunately, because they can prescribe medication, there have been allegations, something that can be proven, that perhaps the DSM diagnoses are influenced by what there is a medication. And so the American Psychological Association, of which I am a member, has debated, like, do we create our own manual? What do we do? I think partially in the response to some of that bickery nitty-gritty. Was it last year or earlier this year? I don't actually remember. But very recently, the DSM-5 TR came out. TR just stands for text revision. And they didn't really change much, just some typos here and there. But the biggest thing they changed is the DSM has always had its own numbering system for diagnoses. And they changed it to match it up with the International Classification of Diseases, the ICD. And I think, I mean, there could be a whole host of reasons, I'm sure, just to like make things clearer internationally. But there's part of me that wonders how much of that is like, because the psychologists were kind of mumbling about switching to ICD, right? So, you know, again, I'm not in those rooms. I don't know what's actually going on, but I can say that we at least need to be skeptical, and certainly people within psychology are skeptical, and you will hear psychologists say things like, well, we just shouldn't give people diagnoses. And these are psychologists who either have giant grants that fund them to see patients, or are in very large cities like New York City, LA, where people will pay out of pocket for therapy, right? But folks who treat and give people, you know, take people with insurance need the diagnosis. And so they can't boycott, they can't not diagnose, right? And so it is a quandary. Again, just sort of like the politics of mental health. So in the DSM-5, again, there's no distinction between Axis 1 and Axis 2. And every disorder in the DSM describes the disorder's main features, subtypes and variations, if there are any, the typical pattern, course, or progression of symptoms, and how to differentiate the disorder from other similar ones. So it'll tell you, like, make sure you rule out these other things. So for example, if you have someone who seems to have had a psychotic break, is seeing things, hearing things, but they've never had any symptoms of this before, and they mentioned being at a pretty rowdy party the night before, you might want to get them drug tested to make sure it's not from a hallucinogenic they took, or ask them about whether they took a hallucinogenic, right? You don't want to diagnose someone with schizophrenia if it was a one-time deal because they tried shrooms for the first time, right? So there are some cultural issues, going back sort of full circle to the beginning of the semester when we talked about these. So some things are not diagnosable. So client reactions to expected culturally appropriate reactions to life events. However, a couple things with this, it's very westernized, right? So that's sort of thought about in like the American, Western European context, what grief should look like. Another caveat is in DSM-5, they changed the grief sort of caveat here. It used to be if someone had lost someone close to them, you had to wait 6 months before diagnosing them with a depressive disorder because grief is a normal part of the process. They took that away. And I think they did it for good reasons. So you didn't have to wait to diagnose someone who might have had pre-existing depression, but this is the thing that kind of pushed them into coming. Right? But there was a backlash, not only from mental health providers, but also from the public. Like, are you just pathologizing grief now? So sometimes some of these get weird press. Phase of life developmental issues. Culturally specific reactions that might seem unusual in Western culture. So like, again, you need to be conscious of things like, how do folks within this culture react to certain things? What is normal in terms of their marriage practices, their grieving processes, exams. And then a lot of programs are not diagnosable, but even people who have a diagnosis, they tend to live pretty normal lives. I mean, US psych majors know, right, that like a lot of people function pretty well. But unfortunately, in the public eye, and movies and TV shows haven't helped with this, right? There's this idea that if you have a mental illness, it's very obvious, you're going to be violent, right? You're going to cause problems for people around you. And in fact, we know that people who have mental illness are much more likely to harm themselves than anyone else, and to be the victims of violence than to perpetuate it. Throughout these recent versions of the DSM, acknowledgement is made of gender, cultural, and age differences. So for example, when you go to diagnose depression, yes, in adults, it's feeling down or depressed most of the day, nearly every day. But you ask a kiddo if they're feeling depressed, and they're not going to be able to articulate that, right? So in kids, it can actually manifest as irritability. It's being like on edge or sort of annoyed about everything. There also is an appendix of culturally specific client experiences, not experienced elsewhere. So the example they give here is Koro, which is a term of Malaysian origin that refers to an episode of sudden and intense anxiety that the penis, or in females, the vulva and nipples, will recede into the body and cause death. So that's very culturally specific. Now, the problem is, this is again framed from a Western perspective, right? So these are all sort of like things you see in indigenous peoples, not white people, right? So for example, as research really started into eating disorders and how media is related, for example, there's this great study they did in Fiji when Western TV was introduced. and no one had eating disorders. And then they introduced it, and the level of eating disorders went up and up and up and up and up. And so eating disorder researchers suggested that we should consider bulimia nervosa a culturally specific diagnosis. And it was dismissed because no, we see it all the time. So there is a lot of cultural bias here that we need to be aware of. And there can be gender bias. So this is my least favorite diagnosis in the DSM. So this is premenstrual dysphoric disorder. Now this was created, I am going to give the rationale, for people who genuinely do seem to have almost like a mood disorder, bipolar or depression around their menstrual cycle. So people with uteruses. But the symptoms are problematic. So it's got to be most menstrual cycles during the past year, you have 5 or more of these, right? And like some of these are like, okay, marked depression, feelings of helplessness, self-deprecating thoughts. Self-deprecating thoughts, I don't know about y'all, but like I have at least one of those a day, right? It's just sort of like the American way. Marked anxiety, tension, or feelings of being keyed up or on edge. Okay. Affective lability, feeling suddenly sad or tearful, increased sensitivity to rejection, persistent or marked anger or irritability, or increased interpersonal conflicts. Okay, so like you have to have at least one of those 4, right? So that does seem like it's diagnosable until you get to like, what if you're just having self-deprecating thoughts? What if other people think your anger is persistent and marked, but it's because you're experiencing discrimination, not because you're on your period, right? And then you have like decreased interest in usual activities, subjective sense and difficulty concentrating, lethargy, lack of energy. This is my favorite. Marked change in appetite, overeating, or specific food cravings. Like literally every person I know who has a period has had food cravings, specific food cravings when they're either PMSing or during MSA, right? And so it's like, I think in a well-trained clinician's hands, this can be used well for those rare occasions where people with uteruses do really struggle around their cycles and might have mood disorder symptoms. In a primary care doc's hand, and they are the ones who are most likely to diagnose any type of disorder and to prescribe medication. This could be misused, unfortunately, not on purpose, right? But it could overpathologize. Sense of being overwhelmed or out of control, and then physical symptoms. What the heck does this have to do with your mood disorder? Breast tenderness, swelling, headache, joint or muscle pain, a sensation of bloating or weight gain. Again, those are physiological things that happen during the menstrual cycle. And we're saying they're pathological. That's why I don't like this diagnosis. But again, this is why it's supposed to be diagnosed when it's interfering with work or school or usual social activities and relationship. It's not just you always have depression and it gets worse that time in the month. We're not giving you an extra. And again, at least 2 consecutive cycles, at least 5 in the past year. So this is problematic to me for those reasons, right? We're pathologizing things. It also makes me concerned for folks who might be having legitimate physical complaints like PCOS or endometriosis, which are usually not taken seriously. And then they might be sort of dismissed with something like this. And so I think that's something we always need to sort of be critical in the back of our mind is like, what is this diagnosis? Are we over pathologizing the person? Or is it actually going to be helpful to give them this label? All right, so again, what we used to call the Axis 1 disorders was everything but personality disorders and developmental delays. These are all considered at least somewhat treatable, and they're reimbursable, which means insurance will pay for you to do therapy with this person. I do have to say, at least with the insurance I have, insurance is pretty darn good. So like, for example, I've looked at like my LabCorp bill afterwards, and they'll bill for like $300 worth of lab work, and LabCorp gets $6 from my insurance, right? When I was seeing someone for therapy, she billed $100 and they gave her 75. So like, that's good, that's livable, right? And so that's something that is good. It also is much more accessible now in terms of like, a lot of people are doing telehealth, what we used to call telehealth, basically Zoom therapy. And so that's more accessible. All right, so these are the broad categories of various disorders. And this in particular, I believe, was the DSM-4 one, and we're going to go through the current ones in a lot of detail. So again, what we used to call access to disorders are long-term disorders where treatment can have little or no effect. That's also changed. With personality disorders in particular, we do have some very effective therapies for some of them now. And again, we don't use the term mental retardation anymore, but it is based on your IQ score. So it's essentially, if you remember, the IQ is mean of 100, standard deviation of 15. And so you don't even start considering someone for developmental delay or other diagnosis until they are 2 standard deviations below that mean. So the standard deviation is 15, so 30 points below the mean of 100 is 70. Okay, and then even then you're looking at mild. But it can go down to profound. And there are folks who just, have no hope of functioning independently because of their developmental delays. The personality disorders we'll also talk about in more detail as we go through things. Interesting side note about these is that these did not change from DSM-4 to DSM-5, even though the working group that worked on them highly recommended that they do change. And the reason they didn't change is because the DSM came out in May 2013, the DSM-5, and in October or November 2012, the working group submitted their revised criteria, and they were told it's too late to switch it out. And yet, they included it as an appendix. And I looked when I got the DSM-5 TR, and it's still like that. You can't tell me that, like, in 10 years they didn't have time to update it, right? So right now, if you open the DSM-5 or the DSM-5 TR, there are 2 different sets of criteria for personality disorders, because that's not confusing. But this is the one we still use right now. Alrighty, so the DSM-5 kind of reorganized some of the categories, and introduced some new disorders, took out some old disorders, tried to rename, refocus things as it went through. So again, we don't have a category called mental retardation anymore. We have intellectual disabilities or delays. So intellectual disability or intellectual developmental disorder would be, again, you're on somewhere of that IQ scale 70 or under. Global developmental delay would be like not only your IQ, but essentially every part of your life. You're not functioning on the level of your chronological age. And you can have, a lot of these will have an unspecified. And this is to fully recognize that as many diagnoses as we have in the DSM, they don't perfectly capture everyone that's probably in need of help. So you will often have an unspecified or an otherwise specified category that you can diagnose folks with and still get insurance reimbursement if they don't quite meet criteria for one of these other things. Then you have communication disorder. So you have things like language disorders, speech sound disorder, which used to be called phonological disorder, where the person has trouble interpreting speech sounds in particular. You can have what they used to just call stuttering, but we give everything fancy names, right? Which is child onset fluency disorder. This is usually actually very treatable. Social or pragmatic communication disorder. This is actually what my kiddo had when we took her for speech therapy. With the power of speech therapy, she was able to overcome it. And again, under autism spectrum disorder, we used to have other diagnoses like Asperger's. No more, everyone's just now on the spectrum. And so people that used to be considered having Asperger's syndrome, and in fact, often really identified with that label, and it was part of their identity, they are now just considered sort of high functioning autism spectrum disorder. A lot of those folks outside of the diagnostic situation will still use that terminology. Attention deficit or hyperactivity disorder, what we think of when we think of ADHD. But an important note here is that a lot of people will sort of ignore the inattentive or the attention deficit piece of this. Folks tend to think of it as hyperactivity, right? But for a lot of kids, and especially girls, they might have the more inattentive type, and it's less likely to be diagnosed because they're not actually disruptive during class, right? They're staying in their seat, but they're just gazing out the window. So that can be a challenge. And then you have specific learning disorders. So those could include what we typically think of as just dyslexia, trouble reading. There's also dysgraphia, which is trouble writing. And often, as you can imagine, those two things go together. Dyscalculia is difficulty doing basic math functions. There are also motor disorders, developmental coordination disorders, stereotypic movement disorders. And then they have a whole category of tic disorders. We tend to think of Tourette's when we think of tic disorders, but it's only one example. So persistent chronic motor or vocal tic disorder, basically like you don't meet criteria for Tourette's, but it's still interfering with things for you. You can give a provisional diagnosis if you're not sure that's what's going on. And again, we always have our other specified and our unspecified. In terms of getting into things that we see more in adulthood, although certainly can be diagnosed in childhood as well. The two categories on this slide used to be just all together under mood disorders. And in the DSM-5, they acknowledge that depression and bipolar are distinct enough that they should be two categories. So bipolar 1 disorder is where you have episodes of depression and episodes of mania. So mania is severe. You are engaging in impulsive behaviors, you're feeling high, irritable, expansive. Oftentimes they become a danger to themselves, not necessarily physically, although it can be, but they're like spending all their money and things like that. So if you have one of those episodes and it lasts 7 days, or it's bad enough for you to get hospitalized, that's a manic episode. And once you've had one manic episode, you're diagnosed with bipolar 1. Bipolar 2 is hypomanic episodes. So you get the same symptoms, but to a lesser degree, shorter amount of time, like 4-ish days. So they'll have that, and then they'll have depressive episodes. Cyclothymic disorder is like the really low grade bipolar disorder. So it's like, they don't necessarily have full depressive episodes, but they might just sort of like persistently feel depressed. And then every once in a while they have hypomanic episodes. Depressive disorders, major depressive disorder is the one we think of, and you diagnose that based on a whole host of symptoms. So not only feeling depressed, but also loss of interest in things you usually enjoy, changes in sleep, changes in appetite, thinking about death or taking your own life, trouble concentrating, things along those lines. And you diagnose it based on how severe the episode is, but also how many you've had. If this is your first one, you've never had another one, single episode. If you've had multiple, recurrent. Disruptive mood dysregulation disorder is a childhood disorder. This is one of the ones that got bad press when it came out, because people thought it was essentially kids just throwing tantrums. And again, if you misread the criteria, that's certainly what it can sound like. But that's not supposed to be what it is. Persistent depressive disorder used to be called this old term dysthymia. It's like for a period of 2 years, you just feel depressed more often than you not. And that can kind of get in the way of things. And then we have PMDD, my least favorite diagnosis. Oh, fun fact about PMDD too, I forget which company it was, but there was a company that their antidepressant patent was about to expire. So they just made the pill pink and called it something else instead of just PMDD. Not even joking, this is the exact same medication. They just made it. And then they didn't have to give up their patent. Yeah. As much as I personally thrive on antidepressant meds, and I know other people who do, it doesn't mean that I have to agree with the ethics of pharmaceutical companies, right? All right, anxiety disorders. And really interestingly, anxiety disorders used to subsume a lot more. And again, in DSM-5, they decided to parse things out more. So like OCD used to be in the anxiety category. PTSD used to be the anxiety category. They've realized those are distinct enough, they pulled them out. So anxiety disorders, separation anxiety we see in kiddos, just what it sounds like, but it's where it gets to, again, a pathological level, where the kid cannot be comforted when their parents are away, will refuse to go to school, things along those lines. Selective mutism is where a child is able to talk and can talk in a developmentally appropriate way, but their anxiety is such that in most situations they feel like they can't talk. Actually, there was a show that used to be on the summers called World of Dance, and J-Lo was one of the judges, and there was a group of little girls who were on it, and one of them had selective mutism, and by the end of the show, she actually talked to J-Lo, and it was a big thing. It was really sweet, actually. So it is an anxiety disorder. There's nothing physically going on. Specific phobia is what we think of when we think of a phobia. Unfortunately, this often disappoints folks. We do not have a giant list of phobias in the DSM. There's not a big phobia listed, which is fear of snakes or arachnophobia. You just have a specific phobia for X, right? And these can be animals, they can be situations like claustrophobia or fear of heights. They can be things like blood injection injury phobia, which gets really dangerous because that often keeps people from seeking medical care when they need it. Or it can be things like fear of throwing up. So wide range, but essentially what happens is when you are around whatever situation or thing you fear, it's overwhelming, you're just overcome by anxiety, you can't function, so you'll avoid anything that reminds you of that, and then that can really interfere with your life as well, right? Social anxiety disorder, once upon a time was called social phobia. Now they're realizing it really is more of a anxiety linked disorder rather than a fear of social situations. This can be general, because you get really anxious if you have to talk to people, or it can be very specific, where you only get it if you have to give a speech in front of people. If you have that type of social anxiety, there's actually fast-acting anti-anxiety meds they can give you, which make you able to take it right before you give your speech. And then you don't have to take it every day. Panic disorder is having repeated panic attacks and then being anxious about having another panic attack, which of course sometimes in and of itself can cause a panic attack. Because what a panic attack is an overreaction of your fight or flight reflex. So your body just thinks it's in danger when it's not. So all the stuff that happens when you have a panic attack, like folks will feel lightheaded. And that's because your body actually diverts blood away from your brain so you don't overthink things and gives it to like your large limbs. You could poof it out of there. It includes things like nausea. That's because digestion stops temporarily when you're in the fight or flight. Again, to divert energy otherwise. Like having trouble catching your breath is actually trying to get more oxygen to your lungs to oxygenate the blood more. Sometimes they'll get like tingling in their fingers, and that's because again the blood's being diverted away from there. They'll have a sense of they're either gonna die or go crazy, and that also is related to the blood being diverted from the brain. And so like a lot of adults will have a panic disorder in their life, or a panic attack, sorry. That doesn't mean they have panic disorder. The panic disorder is repeated panic attacks, and then that worry you're gonna have another one. Agoraphobia translates to fear of the marketplace. It's more than that. Agoraphobia is essentially fear of going out in public spaces because you think a specific bad thing will happen. So you can have agoraphobia with panic disorder. You're afraid to go out in public because you think you'll have a panic disorder and a panic attack and embarrass yourself. You can have it if you have something like Crohn's disease or IBS, so you're afraid you're going to get like diarrhea in public. Or sometimes people with epilepsy will get it because they're afraid of having seizures in public. Or they'll just be afraid they'll be like in a public place and they can't get out. Agoraphobia can get really crippling, so where some people like can't even leave their houses. GAD, generalized anxiety disorder, is one of the more common but less well known to like the lay public anxiety disorders. It is just worrying about everything all the time. The client said to me, I've always been a worrier. I knew I should definitely screen for GAD, right? You feel keyed up, on edge, you might have trouble sleeping, your muscles might be tense from worrying all the time. It can affect, other things in your life, but it's just like you worry about everything and anything and keep chewing stuff over and over. So again, we have this lovely new category, obsessive compulsive and related disorders. And I like this because these used to be kind of scattered all over the DSM, but they're actually very similar in their pathology. So all of these are marked by a specific compulsion to do things. A compulsion is you feel like you have to do it. You feel like horrible things will happen if you don't do it. And you feel like you can't stop yourself. So obsessive compulsive disorder, you obsess about certain things. The stereotypical one is the dirt, right, or contamination one. But you can worry about a whole host of things. So people have OCD. A common one is checking, like, did I turn the lights off? Did I turn the stove off? Things like that. But like, for example, I had this client who just broke my heart where she had been sexually abused as a kid. It was already heartbreaking. But then her OCD was, her obsession was she thought she was going to do something to her own kids. She'd never done anything to her kids. In fact, she'd probably be one of the last people to do something to abuse her own kids, right? Because she had experienced it herself. But it was like an obsession that plagued her every day, like to the point that like her husband had to give her kids baths because she didn't feel comfortable doing it. So we worked a lot on like acceptance and trauma work and hard case. So it can be like counting. There can be a whole host of things that go into compulsions here. And the idea is you have the obsessions, the compulsions make it go away temporarily, but only temporarily, right? So like people that check might like check the light, okay, it's off. And then like 30 seconds later, they're like, but is it off? right? And then they have to go back. People who do have the like dirt contamination will sometimes wash their hands so often their hands start to like bleed and crack. So it can be very severe. Body dysmorphic disorder is the idea of an obsession about a imagined or at least exaggerated physical trait that you think is just so bad that other people must be noticing and making fun of you for it, even if they're not, actually. And so, for example, you might think your nose is really big. And so you might get multiple rhinoplasties. Or you might be obsessed with something about your hair, right? So you spend lots of time in muddy, trying to make your hair look just so. The key case I always use as an example of this is Michael Jackson. You know, I didn't interview or diagnose him, but certainly someone who goes through that many cosmetic surgeries, you start to wonder, right? Like to the end of his life, like his nose was actually caving in because he had too many nose surgeries. Hoarding disorder is an interesting one. So it's like an extension of OCD where you feel like you can't throw anything away because you might need it. Really interestingly, this was not ever in the DSM until the DSM-5. And there was some skepticism, like, did you just make this a diagnosis because there's a TV show about it? I think clearly the people who have it do need help. So it's great that it's here. But they just sort of like, why not? Trichotillomania is a hair pulling disorder. So they will, and sometimes they don't even realize they're doing it, but they'll just pull out their hair when they're stressed, right? I had one student who at least told me she had this. And one time I got an email from her like 1 a.m. and she just said like, I don't know what I'm gonna do with my life. Can we meet tomorrow morning to like talk about grad school? Because I think I'm redesigning everything. And I said, sure, come see me at 8:30. And she came in and half her eyebrow was gone. It's like she'd been that stressed that she just kept plucking. Some of these folks will get like bald spots, things along those lines. Excoriation is the same thing, but skin picking. So like if you have a scab, you'll pick it and pick it and pick it. And obviously that can be dangerous in terms of infection, right? Anytime you're disrupting something that's healing, you can get stuff in there you don't want in there. All right, schizophrenia, one of the most commonly known one, but there's a whole host of other disorders that are related. Really interestingly, they put schizotypal personality disorder here for the first time, acknowledging that it's probably like on the same spectrum. Schizotypal personality disorder is like, you might experience some weird sensations, but not to the point of hallucination. These folks also typically don't want to be around other people. Some because of paranoia, some just because like they prefer to keep to themselves. Delusional disorders, just that, you only have the delusions. Delusions are fixed false beliefs. These can vary from anything to like someone is following me, to like I am Napoleon Bonaparte, and everything in between. Like the sky is falling, literally, right? Things along those lines. Brief psychotic disorder is where you have psychotic symptoms, delusions, hallucinations. Hallucinations are sensory experiences that aren't real. So seeing, hearing, tasting, smelling, feeling things that aren't there. So brief psychotic disorder is a month or less. Schizophreniform disorder is a month to 6 months. You're diagnosed with schizophrenia after you've had symptoms for 6 months. The reason these other disorders exist is because sometimes people will only have symptoms for a month or 6 months, right? But sometimes if you have schizophreniform disorder, it will become schizophrenia. And then schizophrenia is a whole host of symptoms. So in addition to the delusions and hallucinations, you also have disorganization in your thought and your speech and your behavior. So they might repeat things rather than responding to you. really extreme cases, they speak in word salad, like nonsensical neologisms or just words and orders that don't make sense. And then you can also have, and actually sometimes these are just as debilitating, negative symptoms that are more like an extreme depression. Where you have like no motivation to do anything. Like I had a client who was an artist, an art teacher. When she got schizophrenia, she just didn't feel like creating art anymore. Sometimes because of the negative symptoms and also unfortunately the side effects of medication, people will like gain a lot of weight. That particular client gained like 80 pounds after she was put on medication. And so it can be very like schizoaffective disorder is where you have symptoms of both schizophrenia and a mood disorder that start at the same time. And so you can't sort of delineate when one started and the other one. Catatonia is a rare but strange symptom that can happen to people who are experiencing psychosis. They will be non-responsive. Sometimes they will just hold weird poses with their limbs, but they'll also have what's called waxy flexibility. So like if you as a caregiver are worried about them holding their arms up for hours, you'll be able to kind of like bend them like an action figure and hit their limbs down for them. All right, trauma-related disorders, and again, the stress-related disorders. This is a new category. These disorders have always existed. They just put them together for the first time in DSM-5. So we have reactive attachment disorder. This is again a kiddo disorder. Disinhibited social engagement disorder. To be perfectly honest, I don't know much about these two disorders. I am an adult psychopathologist by nature. That's what my PhD is in. And I've never taken the time to really read up on these, so I should probably do that at some point. But I can talk to you about PTSD and acute stress. So acute stress, just like brief psychotic disorder, is the shorter version, up to a month of symptoms. You diagnose someone with acute stress. Some people will only ever get diagnosed with acute stress disorder. Others will go on to get diagnosed with PTSD. In these disorders, one of the reasons these are no longer under anxiety disorders is there's really a whole host of symptoms that you get. So yes, there's anxiety, there's intrusive thoughts, intrusive dreams, nightmares, but there are also other things that happen that are like dissociative. So sometimes when things remind someone with PTSD of what happened, they'll like blank out, dissociate. An extreme version of dissociation is a flashback, where you actually feel like you're back in the moment where the trauma happened. Vietnam era vets, it might be like a car backfires and they hit the deck. For some of my OEF, OIF, Iraq and Afghanistan vets, it was they would be driving, and all of a sudden they'd start driving like in the middle of the road, like straddling the yellow line, because that's what they had to do to avoid improvised explosive devices on the road. One of my clients would be having consensual sex with her husband and have flashback to being sexually abused, right? It can be things like that. They have hypervigilance. They're always on their guard. They'll like sit in corners so that they can see everyone in the room. They will scan things. One of my clients would patrol his like several acre property every night, even though he had knee injuries from the war and it wasn't good for him physically. They will also have an exaggerated startle reflex. So if you are able to startle them, they'll jump a mile. A friend of mine saw a client that his kid woke him up and he didn't know where he was. He grabbed his kid by the throat. He didn't hurt his kid was okay, but they sort of had to teach the kid, like, don't wake dad up when he's asleep. Right. And so it can be really disruptive. If anything reminds them of it, sometimes they'll just like avoid those situations or leave the room. If you're like still in the military and the war reminds you of it, that's gonna get really difficult, right? And then adjustment disorders are where you're having symptoms that are sort of subclinical for something like depression or anxiety, but it's clearly linked to a stressful event in your life. So like, let's say you're going through a divorce, right? And you're feeling pretty depressed about it. But other than that, you wouldn't be feeling depressed. You might be diagnosed with an adjustment disorder with depressed mood. All right, so dissociative disorders are that dissociative piece of PTSD on its own. The one that everybody knows, what used to be called multiple personality disorder many, many years ago, now called dissociative identity disorder, 2 or more distinct personalities, who, depending on the symptoms, may or may not communicate with each other. Often there's just memory blanks, where the person's like, I don't know what I did for 5 hours. And it's when the other personality came out. Now, there are people who are skeptical that this is a diagnosis. And there is unfortunately evidence that there have been times where well-intentioned therapists have, under hypnosis, unintentionally suggested additional personalities to folks. One of the more famous cases is Sybil, who they made a movie about, and there was a book about. A book came out maybe 5 years ago called Sybil, I'm gonna blank on it, Sybil something. And it basically talked about how like a lot of Sybil stories just don't match up to what was there. And like, to me, the most damning part was she had this relationship with her therapist, and her therapist just told her, I'm not going to see you anymore because I'm only going to see people with multiple personality disorder. And then like the next session, Sybil came in and was like, I have multiple personalities. So like, to me, that's like, right? Or maybe coercion by the therapist, who knows? Dissociative amnesia is where something stressful has happened and you do not remember events around it. It can also sometimes affect your like ability to make new memories. It's usually short-term. You can have dissociative amnesia with dissociative fugue, which is where you actually move for a while and take on a new personality. It's not a dual personality, you just like take on a new identity, and then you can come out of it. Depersonalization, derealization disorder, feeling like you're not attached to yourself or the real world. And one thing I should say is most adults have had at least one time in their life where they've experienced this, but that doesn't mean you meet criteria for the disorder, right? It has to happen repeatedly. But it's just this feeling of like, I don't feel like I'm in my own body, or like, is what's going on around me really like what's happening? A lot of times when adults experience this, or even kids, it's because we're really tired, or maybe like stressed, or there's some sort of substance involved, right? But for people who have this disorder, it's more enduring. Somatic symptom and related disorders are where you have physical symptoms, but no matter how much medical workup they do, they cannot find any physical cause. So they are basically your stress manifested as physical symptoms. So somatic symptom disorder, where you have a host of symptoms, again, no physical cause. Illness anxiety disorder is what we used to call hypochondriasis. You're so anxious about being sick that you're convinced you have everything. Conversion disorder is like an extreme of this, where your stress is so extreme that it like really causes severe physical symptoms. It can be things like paralysis, or like loss of ability to use a limb, or numbness. This is really what we used to call hysteria back in the day, what Freud treated. We can diagnose people with psychological factors that affect existing medical conditions. Then there's factition disorder. This used to be called Munchausen syndrome. And so this is where someone intentionally causes symptoms either in themselves, so that's factitious disorder of self, or in others, typically someone they have power over, like their kids or an elder in their care, and that's fictitious disorder to others. They will take things, or like in the case of their kid, give their kid things to purposely make them ill. They might undergo extensive treatments, surgeries, medications, and especially for factitious disorder to others, what used to be called Munchausen by proxy. The best indicator that's really what it is if you separate the kid from the parent and the symptoms stop, right? Yeah, that one's really scary and sad. Alrighty, now we're getting into basic functions that can be messed up by psychological things. So we have the feeding and eating disorders and a couple other things. I'm gonna say, let's take our break a little early tonight, just because I'm really warm, so I need to go walk outside for a little bit. So go ahead, it's about 7, come back around 7:15, and then we'll get through the rest of this lecture, and then y'all are gonna pair up and give each other a diagnostic interview. So folks on Zoom, we'll be back in about 15 minutes. This one just doesn't even have it for me. Sorry, no. Pass on, guys. I'm gonna go ahead and dive back in and people can sort of trickle back in as I chat. Alrighty. So now we're to the feeding and eating disorders. This is my area of specialty, but I know less about the feeding disorders because these were added to this category after I graduated. So I've done my best to educate myself about these. Pica is the eating of non-food, non-nutritive substances. So a lot of the like My Strange Addiction show stuff where they were eating laundry, detergent, sometimes people will eat clay, things along those lines. That is pica. And they have to specify non-nutritive, non-food, because there are some foods and beverages now that are non-nutritive. Like, for example, if you're drinking something like a Coke Zero, right? It's technically non-nutritive, but it's food, right? So you're not gonna, if you're a Coke Zero addict, you're not gonna be diagnosed with pica for that. Rumination disorder, and apologies, this is gross, is where people will kind of bring up what they were eating, chew it more, and bring it back down. Yeah, it's gross. And it's called rumination because that's what ruminants like cows do to digest their food. Avoidant and restrictive food intake disorder is something that, like, so when I go to my annual conference, which I'll do in a couple weeks, like I always try to go to stuff about ARFID because it's a relatively new diagnosis. I would say within the last 15 years or so, it's really come on the scene. And like, we're still trying to figure out why people do this. So this is like, it's not related to your appearance, but people will be very restrictive about what they eat. They will not eat certain things. And it's not just like being a picky eater. They're often like afraid to eat certain things, but it's not like a choking phobia. So we'll see this quite a bit on kids, but you can see it in adults too. So ARFID, as it's abbreviated, is something we're still trying to really parse out. Then we have what are more of the classic eating disorders. So anorexia nervosa is severely restricting your food intake. Typically they're underweight. Although for kiddos who have AN, it can be they are just not gaining weight at the rate they should be. These folks tend to have a lot of physical side effects. They'll lose their hair. They can develop like osteoarthritis, osteoporosis. They'll often stop menstruating. That actually used to be a symptom in the diagnosis. They took it away because so many people with uteruses are on birth control now that they'll often have a period no matter what. So it's not really a good diagnostic criteria. And obviously, for sexist against people who don't have uteruses, right? These folks have a distorted view of weight and shape. They'll look in the mirror and think they're much bigger than they are. And so they think they need to keep losing weight. Bulimia nervosa is where you will binge and purge. So binging is eating a large amount of food in a short amount of time with a sense of loss of control. So they will eat 2,000, 5,000, 10 calories in a sitting, sometimes 10,000. And it's often things your body evolutionarily craves. So like carbs or fats. So for example, I've had clients who binged on whole boxes of cereal, clients who ate whole sticks of butter, because a lot of time what happens in bulimia is we tend to think of the purging as vomiting, but there are different ways you can try to purge the calories, and one of them is fasting. And so, like, I had one client who would try to go as long as she could into the day without eating. So she would get up at like normal time for a college student and would try to go as long as she could throughout the day. So maybe she wouldn't eat till like 3 p.m. when she finally broke down at night. And so then you binge not only for emotional reasons, but because you're hungry, right? And so that's when you eat the things that your body is craving. Purging, as I mentioned, can be fasting, can be vomiting, can be use of laxatives, which make you poop. They can be use of diuretics, which are supposed to get rid of water weight. It can also be excessive exercising. And it's not unusual to have a combination of those. In order to be diagnosed, you have to be binging and purging at least once a week. There were some clients I saw who maybe did it 2 or 3 times a week, some who I saw who did it 2 or 3 times a day. So the severity can really vary. And again, physical things, you can get ulcers on your throat, cavities on your teeth from the stomach acid if you're vomiting, things along those lines. Binge eating disorder is one that was in the like disorders to be studied more in DSM-4, got moved over for DSM-5. We were already diagnosing it. We knew it was a thing. It is bulimia without the purging. The people who are using binging often to deal with emotional issues and don't engage in those compensatory behaviors. You can also have other specified feeding and eating disorders as well. So for example, there is a disorder just called purging disorder, where you don't ever binge, but you purge everything you eat. Elimination disorders, enuresis and endopresis, are where it's very Freudian, actually, to be honest. It's very like, you're either peeing or pooping when you shouldn't be, and maybe not when you should be, and it's related to stress and psychological issues. Then we get into ideas about the sleep cycle. So you can have, independent of depression and anxiety, just an insomnia disorder where you have a hard time falling asleep or staying asleep. So some people will wake up in the middle of the night, have a hard time getting back to sleep. Some people will wake up like an hour before their alarm, not be able to get back to sleep. Some people can't fall asleep, wake up in the middle of the night, and then also wake up before their alarm. So very problematic. Hypersomnolence is where you sleep more than usual. And so again, it's not physically related. It's not because you have mono or something like that. Just something's going on with you where like the way you cope with stress is you just. And sidestep that like a lot of us do that sometimes, right? But just not every time for stress. Narcolepsy is where your sleep-wake cycle is off, your circadian rhythms. So you might fall asleep in the middle of the day. This can be really scary if you fall asleep in the middle of driving, for example, right? Or at work, something like that. And then really interestingly, I'm still not sure why, to be perfectly honest, but they put sleep apnea and other breathing related sleep disorders here. I guess those could be related to stress, but typically sleep apnea is actually due to like respiratory issues and issues with like how things process in your throat, essentially. So if you don't know what sleep apnea is, it's where you stop breathing while you sleep, and typically for very short amounts of time. So obstructive sleep apnea is what I was just talking about. And then central sleep apnea. You can also have sleep-related hypoventilation, where you just breathe way too slowly when you sleep. And then something that seems more like it's related to me is the circadian rhythm sleep-wake disorders, where your circadian rhythms are just totally off. You have trouble knowing when to sleep, when to wake, and it's just like you have no pattern. So non-rapid eye movement sleep arousal disorders is when you don't have REM sleep. And this is when you have troubles during non-REM sleep. There's a separate one for REM sleep, my bad. So REM sleep, just to give us context, is usually when you dream. It's the part of the sleep cycle where your brain is most like where you're awake. And so if you have trouble during that, you don't get as restful sleep. So this would be where you have a hard time in the like lighter versions of sleep, sort of when you're getting down to REM. Sleepwalking, we've all seen that. Could be very dangerous, right? Can be related to stress. Sleep terrors are where you have nightmares and you wake up just screaming. Not fun. Some people who have sleep terrors will wake up in like a paralysis and feel like they can't move, which is even more terrifying, obviously. You could have nightmare disorder where you just have more of those. And then this is the one that kind of cracked us all up when we came out and they're like, oh, there's a med for that. So it just looks like restless leg syndrome. Just doesn't seem like it's necessarily psychologically related, although I guess it could be. The sexual dysfunctions. So these are related to old ideas from Masters and Johnson about the sexual cycle. And so they kind of relate to that. And they're specific and they use gender terminology. So where it says female, think people with like uteruses and vulvas. Where it says male, think people with penises. Delayed ejaculation takes a really long time for completion. Erectile disorder, just what it sounds like. A lot of times there's a lot of psychological issues to not being able to get an erection. Female orgasmic disorder, difficulty having an orgasm. Female interest, sexual interest or arousal disorder is just like not being interested or not getting aroused. That's fine. I don't really care if I'm signed out. I guess it's gonna make me sign back in. Sorry, I was just gonna take away where I had the DSM-5 table of contents floating in there because that was unnecessary. While I was chatting here. There we go. Okay. Genital pelvic pain penetration disorder includes things like vaginismus. When you go to have sex, you actually have pain, and sometimes your body like physically clamps down, so penetration is impossible. Male hypoactive sexual desire disorder, premature ejaculation, and then you can have a substance or medication-induced sexual dysfunction. Now, part of the issue with these is like, there's no diagnosis for being overly sexual, right? And so it just assumes that the underly, that's not really a word, but you know what I mean, undersexual is pathological, right? So like, concern is, you know, what if you're asexual? Or is someone going to diagnose you with one of these, right? When that's just your sexuality. And other things, like I mentioned, these are based on a model that's somewhat outdated now. And they are genderized, which is like, okay, but some of these, like, I don't know why male and female sexual desire have to have different disorders, right? Like if we're having sexual desire, sexual interest, why can't we just like call it that? So yeah, and these are certainly things that cause people distress, but like, you know, we want to make sure that we are not, again, not over pathologizing people. Gender dysphoria now has its own category. This again is a controversial diagnosis. So gender dysphoria is extreme dissatisfaction with your gender identity. It's typically used to diagnose folks who are trans. And it's used so that they get access to the care they need, right? So you can get therapy, you can get hormone therapy, you can get surgery, sometimes covered by insurance, if you have this diagnosis. So for that reason, trans advocates I talk to are okay with this existing. As a feminist psychologist, I think this pathologizes people who are trans, who have always been around, right? Indigenous people have like two-spirit individuals. And so I hope that we'll get to a point someday where we don't need this. But it's certainly better than it used to be when it was called gender dysphoric disorder. At least it's not a disorder anymore. Then we have the disruptive impulse control and conduct disorders. So these are just like stuff that'll usually get you in trouble with the law too. So oppositional defiant disorder is in a kiddo just always arguing, always saying no to things. And like, yeah, kids go through those phases and that wouldn't be it, right? It was just like this becomes that kid's personality, right? Intermittent explosive disorder is like people who have really scary anger, right? Violent outbursts. Conduct disorder is the teenage version of antisocial personality disorder, so I'll talk about these two together. These are folks who don't have a conscience, who will like present as like smarmy or normal, but in fact like don't care about other people. These are the folks who might attack animals. These are the folks that as adults they might be serial killers, or they might be guys on Wall Street that caused the housing bubble and like don't care how many people's lives they screwed up with it because they made money, right? Pyromania is getting a big kick out of setting fires to things. Kleptomania is getting a big kick out of stealing things. All right, this ended up really small, so I apologize. I will read everyone out so that it's easier for y'all to see. So substance-related and addictive disorders, it's really interesting because, yeah.
I have a question on what you said.
Yeah.
I know we talked about like ethics and stuff about in court about like insanity.
Yeah.
Again, those disorders like the stealing one, like it's because they're obviously not insane.
Right.
But cannot be used.
That's a legit question. I don't actually know. Let me Google it real quick. Yeah, I'm not sure if that's ever been used. Let's see. It has not been the basis of a successful NGRI plea. So people have tried to use it, but this says proving kleptomania is no defense. So apparently not. Apparently they don't think it justifies it. Yeah, that's a good question because like I could see that argument and a good lawyer could make that, right? Yeah. But apparently not. Yeah, typically it's like you don't know right from wrong at the time you committed a crime. Right? Typically people that are kleptomaniacs know it's wrong and that's what's exciting about it. So yeah. Yeah, not guilty by reason of insanity is like a weird assessment because you're like not actually using psychological diagnoses as much. You're just saying whether or not someone meets that specific legal criteria for insanity. Right. Yeah, good question though. Like I literally didn't know. All right, so the substance related and addictive disorders, they've added an addictive because they threw gambling disorder on here. And there's some talk about in the future, maybe adding like an internet addiction to here. Although it hasn't been added yet. Certainly I think you could put like a porn addiction here as well, right? And so substance related disorders, we tend to call them substance use disorders now and substance induced disorders. It used to be we made a distinction between abuse and dependence of substance, and now we just use an umbrella for like it's a use disorder, that the use of the substance is what's causing you the problem. And so then we just categorize it by what substance are you using. So alcohol, caffeine, a lot of people are skeptical about this, but if you overuse caffeine, it can have a lot of mental health, but also physical health consequences. Unfortunately, there have been cases of like, I want to say there was like a teenager, maybe young college student who drank like 3 energy drinks in an hour and died as a result. I mean, again, rare, but it can happen. Cannabis related, this one is like somewhat funny to people. Some people are like, you can't get addicted to pot. You can, right? And it's a lot of the criteria for these disorders are like when it's interfering with your work or your social life or your family, right? And so if you're just like high all the time, chilling on the couch and like ignoring your responsibilities, it could be a disorder. I did have a school official tell me once that like they don't mind cannabis use as much because they were like, well, you know, they just gotta sit on the couch and order pizza, so they're not being disrupted. I was like, oh, I get it, right? And one thing I want you to note is that it doesn't matter if cannabis is legal in your state or not, right? Because alcohol is legal, caffeine is legal. It's whether or not it's affecting you psychologically. Hallucinogen related disorders. So this would be things like LSD, ecstasy, shrooms, those types of things. Inhalant. These were popular when I was in high school. I don't think they're as popular now. Just like poppers. People used to like inhale the stuff that makes the spray paint come out. Do not recommend. I don't really recommend a lot of these. Opioid related disorders can be morphine, can be other derivatives of it. Sedative, hypnotic, or anxiolytic related. And again, this one's really important. You can get addicted to certain anti-anxiety medications that are prescription, right? Yeah. That's a good question. As far as I know, melatonin's okay and non-habit forming. Now, if there's other stuff in there, maybe. Part of the problem with melatonin and other supplements is they're not regulated in the same way as medications are, right? So as long as you know what's in there and it's basically just melatonin, my understanding is it's non-habit forming. That being said, there are sleep medications that are habit forming. You kind of have to be careful if you have an addictive personality or like a history of substance abuse. Yeah. But like maybe there will be a case. I don't know. But as far as I know, that's safe. Because you can even give melatonin to kiddos now. They make like melatonin gummies for kids.
Like most parents have babysit for.
Use them. Yeah, we had a friend who like their child just would not sleep, and so they gave her the melatonin gummies and they helped. Yeah. Yeah. Stimulant related can be like cocaine, meth, things like that. Tobacco related, and then the non-substance related, like I said, for now is just gambling, but there might be other stuff here in the future. Then we have neurocognitive disorders. So delirium is a really important one to know about, particularly if you're going to work with older adults at any point in your life. Delirium is usually very temporary. It's often due to some sort of infection, fever. You might even like sort of hallucinate, be really out of it, not with it, not have a great memory. But it's temporary and it's linked to something like often in older adults, it's linked to a urinary tract infection. If you give them antibiotics to treat that, it goes away. Right? But if you don't and you ignore it, it can amplify, right? And then you get to the major and mild neurocognitive disorders. So basically, major is what we think of when we think of like dementias. Mild is usually the early stages of one of these things. Where mild, you have a presumption of being able to like operate on your own, live independently. When you get to a major neurocognitive disorder, there's no pretense of being able to live independently. You're going to need support and assistance. And then you can have these due to various different things. So Alzheimer's disease, I think is the one most people know about, but there's a whole host of other things that can lead to these dementias or neurocognitive disorders. Lewy bodies. So, I skipped frontal time. Okay, so Alzheimer's, we know the pathology behind them is the buildup of amyloid plaques in the brain. It's like junk in the brain. And they aren't cleaned away the way they're supposed to. And then also the neurons, their axons get tangled like Christmas lights that weren't properly put away. And that's going to interfere with your ability to process things too. Frontotemporal is a specific dementia that affects your frontal and your temporal lobes. Shocker. But has a slightly different pathology but similar results for dementia in terms of loss of abilities that are controlled by those areas. Lewy bodies are a different type of gunk that can build up in your brain. Interestingly, people with Lewy body dementia will often have really comforting hallucinations. Like they'll see a dead loved one or a dead pet. And so they won't tell other people because they don't want them to go away. And they know it's a hallucination, which is distinct from like many people with schizophrenia, for example. Vascular neurocognitive disorder is due to strokes. So you can either lose a lot of function with a major stroke, or if you have a lot of mini strokes, what are called TIAs, you can see kind of like a step down in functioning. You can have it due to TBI. This is where, oh gosh, what do they call it? CTE would fall, what football players get from repeated concussions, right? You can also, if you have a very severe traumatic brain injury, right, you can just get it all at once. You can get substance or medication induced. Some people overuse substance to the point that it takes away some of their cognitive functioning. Depending on the substance, it can really screw with the neurotransmitters in your brain. So that is why that can happen. What a lot of people don't realize is end of life HIV. Basically, when you have full-blown AIDS, there are dementia-like symptoms as a result of that. A lot of people don't get to this point now because we do have really good antiretroviral medications that you can take to keep you in HIV and actually be like virus load undetectable. But if something happens where people can't access their medication, things along those lines, end of life can look like some of these other dementias. Prion disease, I want to say, is mad-cow? Does that sound right? I think so. Related to that, Parkinson's is what Michael J. Fox has. It's a tremor-related disorder. As it progresses, it can affect your brain in such a way that, again, you can't function independently, but they're trying to make a lot of strides on treatment for it. And then Huntington's, it's also sometimes called Huntington's chorea. Chorea translates to dance. Huntington's is a movement disorder where like the movements are very fluid and can look a little bit like a dance. That can also affect your brain. Well, I mean, it's affecting your brain to affect the movement, but you know what I mean. All right, so I said we'd circle back around to the personality disorders. This is again that DSM-4 diagnosis set that's been carried forward now for 2 versions of the DSM for some reason. All right, paranoid PD, just what it sounds like. You don't trust other people, you think other people are out to get you. Schizoid is like, you're kind of a weird person, right? And you might be like super eccentric, and it starts to get in the way of your daily functioning. And we mentioned schizotypal before, where you might have abnormal experiences, but they're not quite to like full-on hallucinations. For all 3 of these disorders, you're going to avoid other people. You don't want to be around other people. So the cluster A personality disorders are the odd or eccentric ones. Cluster B are the, gosh, I know cluster B the best, and I'm blanking on what the terminology they use for it. But it's basically like related to mood, dramatic, emotional, things along those lines. Antisocial PD is what we just talked about. These are your serial killers or your serial money abusers, right? Things along those lines. Borderline PD is the personality disorder I worked with the most because you see this co-occur with eating disorders and trauma quite a bit. These are folks who have a lot of problems with identity. They'll put other people on a pedestal one day and think they're the worst the next day. They will often not know how to regulate their emotions, not know how to deal with stress, so they'll self-harm. They will dissociate quite a bit as well. So it's an interesting mix of things. It can make them very difficult to be around, but we do have a very good therapy that works very well for this. Histrionic PD, I always jokingly say these are musical theater majors taken to the extreme. They're very dramatic. They want to be the center of attention, right? And they will like manipulate people to the point that they get that attention. Narcissistic PD, they are just, they think they are the bee's knees. They are on top of the world. The only narcissistic PD client I've ever seen told me he was writing the great American novel. He did not have a single word on a page. This is also where like just you get a lot of interesting nonverbal information, right, from an interview. So typically when I'd ask people in and on a unscripted interview, sort of like, okay, tell me why you came in. They give me like a couple sentences. He talked for 45 minutes, right? He just loved to hear him talk. So, but often below narcissism is anxiety, right? They sort of almost put on airs because they're worried that people actually don't want them. And then the cluster C are the anxious personality disorders. So avoidant PD is like social anxiety, but it's like social anxiety, they want to be around other people, they just get really anxious. Avoidant, it's like they don't trust other people, they're also anxious about closeness for other people. But the nice thing is you can treat part of it kind of like you treat social anxiety, and we have good treatments for that. Dependent PD is you rely on other people for everything. I had a client with dependent traits and she was in her 40s and her husband gave her an allowance. Like, and she was totally cool with that. So it's, you can't make decisions on your own. You really struggle unless you have someone telling you what to do. OCPD is type A personality. So it's about wanting things just so, and we got to get it done and we got to do it now. And like, it doesn't matter what happens socially if they got to do it. I had one client with OCPD who wouldn't go out with her friends if she had wanted to go away because she had to organize it by color and sleeve length. And like, that's fine in and of itself, but like the fact that she wouldn't let herself socialize until she did it is what's problematic, right? She also said like, well, you know, I got in the fight with this person and 2 strikes and you're out. Like, that's not even how baseball works, right? And they're really perfectionistic and it can be really difficult for these folks. Paraphilic disorders or paraphilias are problematic sexual attractions. Often these are problematic not only for the individual, but for the people around them they harm through it. So for example, voyeuristic disorders being a peeping Tom, spying on other people having sex or changing, that's an invasion of privacy, that's illegal, right? Exhibitionistic disorder are people who are flashers, but here they like get off on flashing people. Again, you're now exposing yourself to someone who didn't consent to that. That's very problematic. Rudderistic disorder is where you rub yourself on someone else in a public place. So maybe like a crowded subway car. And again, like that's what's getting you off. Sexual masochism and sexual sadism, I always have to take a couple step backs here and say, you can engage in BDSM consensually and it doesn't have to be a disorder. Get a safe word, all that good stuff. Sexual masochism, however, is you only get off on punishing other people or making other people feel pain, and it's not necessarily consensual, right? Again, problematic. Sexual sadism is you get off on people punishing you, right? And again, these only really become a problem if, again, it's not consensual or the person themselves is disturbed by it, right? Pedophilia, obviously, always a disorder, always problematic. I can't tell you the number of clients I had who, like, a lot of their psychological issues stemmed from being abused as children. So, And then ones that aren't really like hurting anybody else. But like, again, they're only disorders if when the person comes in, they're disturbed by them. Fetishistic disorder, just what it sounds like. Having fetish usually for a non-human thing or like a body part. So it might be wearing underwear of the opposite sex or shoes or even feet, right? Things along those lines. But again, those are fine unless it bothers you, right? And then that's where this becomes a disorder. Transvestic disorder is specifically getting off from cross-dressing. This is obviously not being trans, it's very distinct from that. I don't actually know, now that I think about why it's its own thing. I think you could probably just put it under fetishistic disorder. If I could write the DSM, right? All right, we're gonna skip over these role play activities just because I want to get to you all being able to give each other these interviews. So as I mentioned, we used to indicate the general medical conditions on the diagnosis. Certainly, if I were still practicing, I would do this, somewhere in my report, even if it wasn't with the diagnoses, just because your ability to function is affected so much by your physical health, right? We also always want to note, again, even if we're not formally doing it with the diagnosis, whether there are major environmental issues going on. If the person is in an abusive environment, if they just lost someone very close to them, if they're having a really stressful time at work, you want to indicate that somewhere in the report to give context. And again, we don't use the GAF anymore, which in my opinion is a little bit of a loss because it was just a nice, quick way to look at the person's overall functioning. However, how do you make a diagnosis? There's a decision tree within the DSM that helps you decide, like, what if they have symptoms of depression and anxiety? What do I diagnose them with, right? And so, and you can have more than one diagnosis. That's important to know. So this is how you would do it within DSM-4. Here's how you would do it today, right? You list whatever diagnosis is primary, causing the person the most issues first. So for this person, it's avoidant personality disorder. And then you would list, that they're also having an adjustment disorder with depressed mood. And again, here we see this person's going through a divorce. So I would indicate that in the report, right? This person's going through a divorce, that's what's causing them to experience depressed mood. Sometimes, unfortunately, insurance will influence this choice. Some insurances will pay for an adjustment disorder diagnosis, some won't, right? And so you might list whichever one the insurance is going to pay for first. And in that case, if the person has that diagnosis, you're not technically lying, right? You're just getting it so that person doesn't have to pay out of pocket. But it's not great feeling, right? Because we want to be ethical and truthful. Obviously, if you're working in a training clinic where people aren't paying, doesn't matter. If you're working in a grant-funded system where the patient doesn't have to pay and you don't have to bill insurance, doesn't matter. Even at the VA, it mattered less because a lot of the folks I saw were what's called service connected, essentially like being on disability for their psychological diagnoses. And so the VA then pays for anything related to what you're service connected for. And you have insurance with like copays for the other things. Oh, something's going on in terms of sports. I was like, why is there a buzzer? What's happening? All right. So diagnosis is part and only part of the whole assessment process, right? So you want to make sure that you are keeping other information in mind, right? And not just this person has a diagnosis and that's it, right? We don't want to define someone by their diagnosis, but again, we often need the diagnosis in order to get that person insurance paying for it. And sometimes, like I mentioned earlier, it can be really helpful in deciding like what treatment's going to help this person. Alrighty, so what we're gonna do next is the structured interview. And so I'm gonna try to like walk Zoom people through it as well as people in person. The formatting of this is a little weird, and so I'm gonna try to walk you through it. The first thing you're gonna do is the screening module. And the screening module just says, basically would let you know what other modules, what other sections would you want to go through. I'm only going to have you go through the screener, the mood episodes, and anxiety. Oh, I think I threw in eating disorders because I eat too. But this just gives you an indication of all the things that this diagnostic interview covers. So this is called the structured clinical interview for the DSM. And what you do as the interviewer is read what's in this big column here. So like for the screener, has there been any time in your life when you had 5 or more drinks, beer, wine, or liquor on one occasion? Pretty much everybody's going to say yes to that. I mean, unless you're someone who doesn't drink alcohol at all, I do not judge one way or the other. But especially for college students, I know that's a yes. Does not mean you have a substance use disorder. Just means you partied once, right? If the person says yes to something, you circle 3. 3 means yes. If the person says no, you circle 1. There's a 2 for like maybe. But I never used the 2 diagnostically. What I would do is just query them more. Like, tell me more if they were so like, I don't know. Well, let's think of this through, right? How would you answer? So in this case, for the screener, you're just going to go through and get yeses or nos for all 12 questions. And then you're going to start with the depression section. And again, you're always going to read what's in the leftmost column, and put it close to me. And then what will be in the middle column is the actual diagnostic criteria. And what's cool is that shows you how they translated those criteria into the questions you ask your person. And again, remember, as you are answering these, you get to decide if you're going to be you or if you're going to be a character, right? And maybe your character has a substance use problem and depression. I don't know, but if you just want to be you, totally cool. Here again, if they say yes, you circle 3. If they say no, you circle 1. And then there will sometimes be little instructions. So like for depression, the first 2 questions are, has there been a period of time when you've been feeling depressed or down most of the day, nearly every day? I have this one memorized because I had to ask every single client I saw this question. So, if they say yes, you just keep going. But if they say no, we just ask the next question. What about losing interest or pleasure in things you usually enjoy? If they say no to that, there's a little instruction here in a box that says, if neither item 1 or 2 is coded 3, essentially they don't say yes to either, then you skip ahead, basically. But if they said yes to either of those, you just keep going through all the questions. And then when you get to the end of that section, then you just go on to the next one. So then the next section I have you all doing is generalized anxiety disorder. So here you ask, in the last 6 months, have you been particularly nervous or anxious? And again, if they say no, you circle 1, you go on. They say yes, you circle 3, and you keep going through all the questions for that disorder. And then, as I mentioned, I threw in bulimia just because I'm an eating disorder person. And then again, you can kind of see where some of these questions are and what they might look like. With the modules you have, once you sort of figure out the system, it'll probably take you 20-ish minutes to get through them. But if it takes you longer, it takes time. I am going to float because I know people have questions when they do this one, just because the scoring is so weird. So fully acknowledging that. If your partner is not here, you can see if anyone else has a partner who's not here and pair up with them. And Zoom people, give me just a sec, and I can show you where I have this stuff posted online. Yeah. If your partner's out here, the other thing you can do if you wanna wait for them to do this is to work on your IRB. But yeah, I would say try to find somebody, and your assessment report can end up being an amalgamation of everybody else. Of, like, I've had people who've had to, like, their partner dropped the class, so they finished with their mom or something, and that's fine. So folks on Zoom, I'm gonna stop share, and I am going to find that link for you all and share it with you. Yeah, that's cool, yeah, and if your partner's not here and you wanna grab extra copies, because you know you're gonna see them, that's also fine, I have those. And Dr. Urban, I have here, yeah. All right, Zoom folks, I'm actually gonna share screen again, because I forgot I posted it on Blackboard, so you're gonna be able to get to it right from there. So if you go to Assess Report Materials, and you scroll down. Oh, it's not here. I will get my laptop and post it. Because I know I have the PDF. So I'll get my laptop and post it. It should be posted within the next 5 minutes. If you want to work on it. The other thing I can do is I'll leave them in the box on Dr. Jackson's old door if any of you want to stop by and grab them to do them with your partner at some point. But I will go get my laptop and post those now. But since we're going to be quiet in here, I'm going to go ahead and release you from the screen doom of Zoom. And I will hopefully see y'all next week. I hope everybody feels better who's sick. Of course, go for it.